Tonight for my IVF answers. My name's Garrett and I am presenting for you tonight, and we have Dr. Harry Karpouzis, the director of Pelargos, IVF clinic in Greece, coming to do a presentation for us this evening regarding about fresh versus frozen embryo transfers. So we already have some questions that have come through, and we will ask them after the presentation is finished. But if you have any questions as we go along, please just pop them in the chat, and then I can ask Dr. Harry at the end. So over to you, Dr. Harry, if that's okay.
Thanks,
to start with the presentation.
Thank you for the introduction, and hello to everybody. We will be talking today about fresh or frozen embryo transfers. What is the right thing? And it's a very important topic because embryo transfer is in any IVF. IVF finishes there, and the only thing that you expect after that it's the pregnancy test. So if we will freeze or if we will go on a fresh transfer, it's a very important question and a very important choice every time. So let's start by definition for people that are not aware of what is a fresh and what is a frozen embryo transfer. We will talk about that later in our slides. We will give the latest evidence that exists behind what is better. We will say which categories of patients benefit most from each of these approaches. We will talk about safety of fresh transfers and frozen transfers, and if they are related to any obstetric issues as well, if someone gets pregnant. And we will say a few things about how we decide. So fresh transfer, it happens, and we do it when we transfer the embryos straight after the egg collection. So when we collect some eggs, we fertilize them, we have day 1 embryos, and then we leave the embryos to grow to day 3 or day 5. In our clinic, we have a day 5 policy for all the embryos right now. And if we transfer 5 days later, this is a fresh embryo transfer. It happens in the same stimulation cycle. So you finish egg collection and embryo transfer in one go. And the difference is that the hormones go sometimes quite high during the stimulation. So there are some theories that say that the endometrium, the implantation window, is exposed, the endometrium, to these hormones, and it can possibly affect the implantation window. And frozen transfer, we do a frozen transfer when we decide that we will not do a fresh transfer, but instead of that, we will freeze all the embryos. The method that we freeze the embryos is called nowadays vitrification. Most of the units do vitrification, of course. And the transfer happens at a later stage, after 1.5 months, 2 months, or even later if someone wants to delay it. The freezing does not affect the quality of the embryos. The difference is that you wait for the hormones to cool down and you transfer in a better prepared endometrium and in a more controlled environment. So at some point in the past, we were saying that fresh transfers were much better than frozen. We were trying to avoid freezing. And then suddenly freeze-all became very in fashion. And we reached a stage that I think that we were doing frozen transfers even when they were not really needed. But freeze-all has become very popular, and it has become very popular for one and only reason, which is vitrification, because it changed the way that we are freezing the embryos now in comparison to what we were doing before. With vitrification, we know that the quality is usually not affected, that the survival rate after the defreezing is more than 95%. in some units even 98, 99%. And the big benefit from that is that you really reduce the risk of hyperstimulation. Hyperstimulation is the only important complication of IVF. And in the past, we had a lot of hyperstimulations. Nowadays, with the freeze-all technique, and when we appropriately choose the trigger injection as well, the hyperstimulation rate should be close to zero. I mean, in our unit, we have a 0 degree of hyperstimulation, severe hyperstimulation, especially in the last like 2 or 3 years. Also, PGTA, which is the biopsy to check the chromosomes of the embryos, has gone into the life of IVF more and more. It has a lot of benefits. And when we do PGTA, especially with the technique of NGS that we do it, we don't have the results on the same day. So we freeze. We wait for the results of the biopsy to see if we have a chromosomically normal embryo, and then we can transfer on a frozen transfer without really affecting the freezing the quality of the embryos. And after we know if the embryo has normal chromosomes or not. The hypothesis is that the endometrium is not affected by the hormones that sometimes go quite high at the time of the IVF, of the stimulation, and this might improve the chances of implantation as well. And we know that some of these hormones can affect the implantation window, can affect many things that play a role in the implantation, cytosines, growth factors over there, even the local immunology of the endometrium, because the hormones can be immunomodulators, can change actually the local immunology of the endometrium. A very important study that came in 2025, a randomized study in many different centers with quite good evidence behind it, that suddenly said that, okay, listen, freeze-all is not always a panacea. It's not for everybody. I mean, sometimes we might need to prefer to do fresh transfers, which is something that we had forgotten in the previous years. And this study actually has proved that in poor prognosis, poor ovarian reserve patients, the live birth rate after fresh transfers can be 40%, and the live birth after frozen transfers 32%. So it gave an advantage in fresh transfers over frozen transfers for poor ovarian responders. And it actually said that the freeze-all should not be a universally superior method. Of course, there are many different parameters here. And what I will say in the presentation as well later is that the decision needs to be completely personalized. So when someone cannot do PGTA, either for financial reasons or for other reasons, when the endometrium is okay before the egg collection, when the progesterone levels are okay, and when we don't have a special protocol like double stimulation protocol or luteal phase protocol, or when we don't want to bank embryos, because this is a solution as well for poor ovarian responders, that we bank embryos, we freeze, we repeat, we freeze again, and then we take the embryos and we put them back. So when we have a simple IVF, and there are reasons of doing that, and we don't have any of these parameters, then a fresh transfer might be of benefit in comparison to just freeze. What happens in normal responders? I mean, most of the evidence says that in normal responders, we have similar outcomes. Again, the same parameters that I said before play a role, of course. And what happens in PCOS or high responders? In this case, the estrogen levels and the progesterone before the time of the embryo transfer is going quite high. And in these cases, it's clear evidence that a freeze-all technique to freeze all the embryos is much more beneficial. The same thing might be happening with lower evidence with patients with endometriosis, because in endometriosis, we prefer sometimes to freeze the embryos so that we can downregulate the ovaries before the frozen transfers so that we can minimize the disease of endometriosis inside the tummy and then go ahead and transfer. The difference every time depends on each patient, and personalization is very important. The decision is very important and depends on each case. Definitely, when we do PGTA, we need to freeze. And always, we need to take into consideration the endometrial thickness as well, because sometimes we go for an egg collection and we say, okay, can we do a fresh transfer? But we see that the endometrium might not be the right thickness. In these cases, it might be better to freeze, of course, to check why this is happening and to transfer on a frozen cycle. When we have poor ovarian responders that they do not want to bank embryos, when we have poor ovarian responders that they cannot afford to do PGTA, when we have poor ovarian responders that they do not have endometriosis, when we have normal responders, but in personalized cases that we don't have all the above criteria. When cost is an issue, because especially with medical tourism, to freeze, to travel back again, to pay for the freezing might increase the cost. Or for any reason, when patients want to have a quicker time to pregnancy, then fresh transfer can be preferred in comparison to frozen. The estrogens are inevitably increased during a stimulation process. When we have high responders, they are increased more. When we have poor responders, they are increased less. Sometimes they can reach non-physiological levels, higher levels than what it should be. And the same with progesterone. And this causes the implantation window sometimes to shift. So these hormones can affect the implantation, and also they can affect the local immunity at the endometrium, and many small factors over there that some of them are even unexplained, cytosins, growth factors, interleukins, and all these things can affect an implantation. So that's why in high responders, that's why in polycystic ovaries, we always prefer to freeze, because the effect of the hormones is higher in these cases. Something very important that we forget, generally in reproductive medicine, because we are interested in getting someone pregnant, but then the obstetrician takes over the pregnancy. And we need always to think about what is happening in a possible pregnancy. And we have a very good meta-analysis with a lot of cases that has showed that the frozen embryo transfer, in comparison to the fresh, has showed a reduce in preterm births, a reduce in the low birth weight of the babies, in reducing small for gestational age babies. And on the other hand, it can cause increase in large babies and increase in cesarean sections. So this is something that we need to take into consideration as well. So advantages, disadvantages of a fresh transfer, faster time to pregnancy. But of course, this needs to be analyzed. It's not that easy, because the important thing is someone to get pregnant. If someone has a reduced chances with a fresh transfer to get pregnant, in the end, the time to pregnancy will be longer. So lower cost, yes. But again, if we know that fresh transfer has some good chances of work, always, of course, if we don't want to bank embryos and we don't want to do PGTA, a fresh transfer has some benefits. And the disadvantages, of course, is that it always gives you a small risk of hyperstimulation. And what we've said before, that the PGTA is not possible and that the endometrium can be affected by the hormone levels. And that's why it is important, and we do it in our clinic, to measure the levels of progesterone if we are considering a fresh transfer at the time of the trigger injection. For frozen transfers now, it is, of course, safer if we are talking about PCOS, polycystic ovaries, and higher responders. Might be of benefit in endometriosis. We have some good data behind it. It also enables to do special protocols like double stimulation protocols, like luteal phase start protocols that we do it sometimes in poor responders. It always is possible to do PGTA. We can bank embryos, as we said before. It is more flexible scheduling because a frozen embryo transfer can be very nicely organized. And of course, it has some disadvantages as well, a higher cost most of the times. You need to have a good laboratory to have good results with frozen embryo transfers. If you trust your laboratory, freezing is not a problem. And of course, you have a delay in the treatment. The freeze-all for everybody is a myth. I mean, it reached the stage that it became like a fashion, but it's not like that. There is no one-size-fits-all. Fresh transfer should not be overruled for everyone, especially in medical tourism, that lots of people, especially traveling from long distance, they would prefer, if possible, to do everything in one go. Personalization is very important. Taking into consideration the patient priorities is very important. And of course, some factors like the progesterone levels at the time of the trigger, the risk of hyperstimulation, if someone has polycystic ovaries, endometriosis, all this should be taken into account. As a general algorithm, we do fresh transfers when we don't want to do PGTA, when we don't want to bank, when we don't have any endometriosis, when we don't have polycystic ovaries, when we have a normal endometrium, and when we have normal progesterone levels at the time of the trigger. We do frozen transfers when we have PCOS, when we have endometriosis, when we have high estrogen levels or progesterone levels at the time of the trigger, when we have endometrium thickness issues, when we want to do PGTA, and when we want to apply special protocols like double stimulation or luteal start. Fresh frozen is important, of course, but what is most important is the age of the woman, is the embryo quality, is the chromosomes that the embryo has inside if we do PGTA, is the laboratory quality and how efficient is the laboratory and how good are the processes in the laboratory. A bad laboratory can destroy a cycle. And of course, personalization again and again and again is the most important word generally in IVF, but in the decision between fresh or frozen transfers as well. Endometrial receptivity plays a role, and when we have recurrent implantation failures, there are specific tests that need to be checked before we implant an embryo, and all these things can happen before a frozen transfer. And it definitely helps the decision, but it's secondary. There are more important reasons of why an IVF would work. Regarding the frozen transfers, it's not only fresh or frozen, but it is also what protocol we should choose in order to do a frozen transfer. It matters because we have many different ways of transferring an embryo. For endometriosis, for adenomyosis, for fibroids, we prefer to suppress the ovaries with GnRH injections. For most common protocol of transferring an embryo is estrogen and then progesterone, which gives better coordination, especially when the people coming from abroad. And the doses, of course, matter because higher doses of estrogen, higher dose of progesterone can affect the implantation window. We do embryo transfers with letrozole and Ovitrel as well, which is like a semi-natural cycle, frozen cycle. And of course, we can do completely natural cycles, which are more difficult to coordinate when someone is coming from abroad, but they have quite good statistics in women that have a natural and regular cycle. Natural cycles have a better perinatal profile in comparison to frozen transfers. And frozen transfers, when they happen with HRTs, with hormones, they can increase slightly the risk of hypertension in pregnancy or small babies in pregnancy. So if we want to take some messages for home from all this presentation, we keep that freeze-all is not universally superior, that freezing should be the only option in PCOS and high responders. We keep that we always need to check the progesterone levels at the time of the trigger injection to make a decision if it worth doing a fresh transfer or not. Obstetric profiles, if someone gets pregnant, differ in each of the two, but both are safe. Every case is different. Personalization is the future of the IVF. And the ovarian response of a patient, if someone is high responder or low responder, the biology of each person, the patient's priorities, and the laboratory are very important factors to help us make the decision.
Oh, I'm back. Thank you. Oh, yes, I'm back. Thank you very much for that. That was fantastic. And we've got some questions that have come through. If you have any more questions, please just pop them in the chat and we can get to them as we work through. So we'll start with the questions that were sent through to us initially. So one from Melissa. I think part of this has already been answered, but that the second half hasn't. So should progesterone levels be checked before effect? I had a premature rise in progesterone after stims in 2 ICSI cycles, so fresh was not recommended. Unsure how to prevent this for the next cycle in order to be able to try a fresh cycle.
Okay, sometimes it is very difficult. Yes, I mean, every unit has its own policies, but we always check the progesterone levels before a frozen embryo transfer, but also at the time of the trigger in order to decide if a fresh transfer is possible or not. In some cases, it is inevitable to have a raised progesterone at the time of the trigger, because we have clear evidence nowadays that the more eggs we get, the more we increase the chances of some of these eggs being chromosomically normal and give you a pregnancy. So having this evidence, when we try to stimulate the ovaries, the progesterone levels can go high and the estrogen levels can go high. So freezing should not be avoided in these cases. And we shouldn't really try to get less eggs or do the protocol not correctly in order not to have a fresh transfer, in order to have a fresh transfer. So in cases like that, we keep going with the protocol. We try to get as many eggs as possible. And if the progesterone is above some levels at the time of the trigger injection, it's freezing. You freeze the embryos, nothing happens to the embryos, and you prefer to put the embryos on a frozen transfer.
Yep. Okay. Thank you. Thank you. Then we've got one here from Emma. Can the use of aspirin and Clexane in a patient prone to uterine polyps make them grow? Is there a need for them if you don't have any clotting issues?
No, I mean, a polyp cannot grow because of Clexane or aspirin. It does not have to do with that. Now, the second question is quite a nice question, actually. The truth is that no, aspirin and Clexane are not for everybody, and they don't need to be given in every single cycle. I mean, we need to give them for specific reasons. I mean, when we have antiphospholipid syndrome, definitely you need to take them. When we have some thrombophilia issues, yes, you need to take them. When we have some reasons that show that the risk of clots is increased, because don't forget that after the embryo transfer, during the collection, the estrogen levels go quite high, and this is a risk factor for clots. And if someone is obese, if someone is more than 40, if someone has raised estrogen levels or anything like that, has a long travel to go back home, then we can give the Clexane as a precaution. But there is no evidence that aspirin or Clexane will increase the live birth in every single IVF.
Okay, thank you. Then there's one here from Mary. Should I PGTA test at the age of 36?
Okay, listen, I'm a big fan of PGTA. If I could do PGTA to everybody, I would do it. But the truth is that, first of all, in Greece, by the law, you are not allowed to do PGTA in the age of 36. You can do PGTA when someone is more than 38 by the national authority. or if someone has a history of recurrent implantation failures or recurrent miscarriages. So the thinking behind that is that when you do PGTA, you remove some cells from an embryo. So hypothetically, you cause a minor injury to the embryo. The truth is that in experienced laboratories and embryologists, the injury to the embryo is very minimal. But despite that, you need to balance in every decision the advantages towards the disadvantages. When someone is young, less than 38, doesn't have a relevant history, the advantages might be less than the disadvantages. So it's not necessary for someone who is 36 to have PGTA. In many different countries, etc., might not be allowed by the national authority to do it as well. But PGTA has, in general, some benefits, and the main benefit of PGTA actually is that it decreases the risk of miscarriages, and miscarriages mainly are related to chromosome abnormalities, and they are not eliminated with PGTA, but it is reduced. And also PGTA gives you selection. If you have many embryos, not all of your embryos will be chromosomically normal. So by doing PGTA, you select which of these embryos are chromosomically normal so that you transfer these embryos with better chances and without the need of transferring embryos that finally will not work. So PGTA for me is quite important, but it's not for everybody, no. And in some cases, the advantages might not overweight the disadvantages.
Okay, thank you. Thank you. Next one is I've just turned 43 and considering a 7th round of ICSI. Low ovarian reserve, very mild superficial endo, previously did PGTA, 2 euploids, 1 aneuploid at age 40. Would you recommend a fresh transfer?
Okay, it's I mean, we don't have all the things that we need to make a decision on that. Okay, we need to go through the previous cycles to see what exactly has happened. I understand that through the previous cycles, she managed to get 2 euploid embryos. These 2 euploid embryos should give very good chances. And if she transferred these euploid embryos and it didn't work, this is an unexplained failure of implantation. So we need to investigate about other reasons of why it is failing. Might not be the embryo the case. We have immunology issues. We might have chronic endometritis. We might have problems that can be seen in hysteroscopy, blood clotting issues. So all these things need to be investigated, first of all, before you transfer the next embryo. To be honest with you, in the age of 43, and especially with the history of recurrent implantation failures, especially with euploid embryos, I wouldn't transfer an embryo without really PGTA-ing again. Because if it fails, you will go and ask the doctor why it failed, and the answer would be, I don't know, because I don't know what the embryo has inside. And given of the fact that we are talking about 43, I would freeze, I would do PGTA again, I would freeze, and I would check other things, all the things that we can check, before I put a euploid embryo back.
Yeah, thank you. And I think from over here in the UK, different clinics vary so greatly, and I think, you know, if you're with a clinic that doesn't necessarily believe in immunology testing, then it might be, you know, good to get other eyes.
Immunology, of course. Listen, immunology does not have a conclusive evidence behind it, and it is normal, and there are different approaches in different clinics. And you don't check, of course, immunology for every single patient, okay?
Right.
But when you have 2 failures with euploid embryos, you need to investigate things before you transfer again, because if you are missing something, there is some evidence behind immunology, and if you personalize the approach of immunology as well, you might find the reason of why it hasn't worked before, and you can treat it. Otherwise, you keep transferring embryos. And
Yeah. Well, thank you. And I guess I've got one question, because you covered a lot there. I suppose my question would be more on the emotional side with the work that I do with my clients. And I see a lot of clients not even really realizing that a freeze-all would be an option. So they'd go through the whole IVF process. And I guess that's down to the clinic a lot of the time for not managing their expectations. So there'd be a case of that they might have been kind of mildly overstimulated and they're kind of, we're going to halt it here. And that can be really, really hard for a patient or a client to accept, isn't it? Because when they're in it, they just want to kind of go. So I just wonder how you kind of manage that. Do you speak to your patients up front?
It's a very nice question, and it's very good that you posed this question, because it's a very common question actually by patients as well. So what I will do, will I have a fresh transfer or a frozen transfer? I think it's very important before the start of the treatment, the fertility specialist to explain all the options. If you can have a plan in advance, you need to say it. So, for example, in AMH of 5, 6 and polycystic ovaries, you know in advance that you will not transfer fresh. And you need to say that you will not transfer fresh. Your stimulation will last for like 9 to 12 days, and we will freeze the embryos and you will put them at the later stage, because you will not hyperstimulate and because you will have better chances. Okay. When you know in advance that you need to downregulate the ovaries because you have severe endometriosis or anything like that, you again explain it in advance. There are some possibilities and some cases that you cannot be sure if a fresh transfer is possible or not. So again, it is very important to discuss it with the patient, and especially when people are coming from abroad, because they need to know how many days we'll stay here, etc. So you need to tell them that we will try to do a fresh transfer if this is the case and if you prefer it, but I need to tell you something. I need to tell you that if by any chance your progesterone levels or your estrogen levels are higher than what they should be at the time of the trigger injection, then I will propose to you to freeze, because if we transfer, A, you will have a risk of hyperstimulation, and B, it will not work. You reduce your chances.
Yeah.
So you give the options in advance. It's very important to discuss it with the patient. And then, of course, the patient knows what to expect, so that will not be on all this psychological distress as well, which is really understandable.
Yeah. I think it's when it's a big surprise, isn't it, that it's the problem. Right. I think that is all of our questions. So thank you very much. Thank you for your time this evening. And thank you for everybody that's joined us and that asked their questions. This obviously is on YouTube, so please follow for more interesting evenings like tonight, and give us a like if you enjoyed it. So thank you very much, Dr. Harry, and thank you for your time.
You are welcome, Carly, and I hope I helped.
You did. I'm sure you did. Thank you very much.
Bye-bye.
Bye-bye.